So hello everybody. My name is Corrado. I'm here with Simona Costache for this latest webinar today about mismatch repair. It's particularly focused on colorectal cancer because we are going to have a circulation for colorectal cancer mismatch repair, but we'll talk about maybe other solid tumors as well. Let's kick the ball and talk about timelines. So 1967, I dug out the original paper that Henry Lynch wrote. He was an observational physician, and he had this cohort of patients he was interested in because they seemed to have familiar cancer. And he just described this. And then years later, Lynch syndrome became an established name for patients that had this kind of tumors. Classically was colorectal cancer, but not necessarily colorectal cancer. And it's only several decades later, 1993, where 3 papers appear contemporarily in Science and 1 paper in Nature describing the molecular alterations linked to Lynch syndrome. And several years later, in 2015, the Nobel Prize in Chemistry was awarded to these 3 gentlemen, and Paul Modrich was the one that, for various advances in DNA repair mechanism, and Paul Modrich was the one recognized for mismatch repair. And only about 3 years ago, but this is the paper, but the publication, the ASCO publication and the permission came a year earlier. There was a recognition that solid tumors of any kind with mismatch repair deficiency benefit tremendously from immuno-oncology, so immune checkpoint inhibition. And it's the basis for to be granted the license for.
And I think this we should keep in mind, especially when we receive for testing for mismatch repair. Ideally, it will be everything one go, right? Mismatch repair, PD-L1 and everything. But if not possible, then it is good to start with mismatch repair, and especially if it is deficient, then yes, you can also give PD-L1.
Yeah, because remember, in colorectal cancer, PD-L1 is not a biomarker recognized for treatment. Not yet for treatment, but mismatch repair is.
Yes.
So excellent. So 1967 to 2022 is kind of a long course. So just a few slides to look at the theory or the schematic kind of theory about what are the mechanisms that prevent, I wrote here, but really actually also facilitate, because sometimes mutations are necessary for our evolution. So it's a both can be seen both way, prevent mutations. So in for the DNA copying, there is a proofreading. So it copies error, it looks at errors during synthesis, and then it changes immediately. Or if the proofreading enzymes don't work or didn't detect this, then there is the mismatch repair. So this is during replication. Of course, when there is DNA damage, then there are different mechanisms. So there is a chemical reverse or excision repair and double-stranded DNA break repair, which are now very topical when we treat patients that have defect of the DNA double-stranded damage. So platinum comes into use of platinum, and use of PARP inhibitors come into play, but that's a different matter. So there are these 2 different things. One is because errors generated during the copying, during the synthesis, and the other one is because something happened to the cell damage. So proofreading is really simple. Most or a lot of DNA polymerases have a proofreading mechanism. So if the wrong base is added, it's detected, and then it is immediately cleaved and put the right base put in. And they repair the greatest majority of misprints. However, if the misprint is not detected, and here there is this little bump because it's not really coupled very well, because it's the wrong base, then the mismatch repair detects this defect, this unevenness. Is very much a physical system, and there are various elements of this DNA repair system. One of it cuts out a piece of DNA that includes the error. Another one replaces the DNA, now hopefully copying it correctly, and then you need to ligate these ends, so there is a ligase at the end of it. So I told you this is a bit of a physical system. These are enzymes, so there are recognition, there are complex molecules, three-dimensional structures that associate with each other. These are dimers, and they form a bigger molecules that then clamp the DNA and slide along the DNA and can detect unevenness in base pairs. And then, so this is the sliding clamp that recognize, and then there are associated molecules. Look how many molecules that are associated. And I think this is a nice picture to say that the Lynch syndrome, so the familiar inherited things, they are typically due to errors in these clamps, in the enzyme in these clamps. But actually, look how many other molecules can go wrong, and a very small proportion of inherited defects or mismatch repair are due to mistakes or mutation in these things. A small percentage of each, you know. So classically, there are two heterodimers. This MAT-S and MAT-L. MAT is the inheritance on how these systems were found, because they were found in bacteria. And they didn't really know they were dimers, in fact. They thought there was one molecule. And if you want to see a little bit more this three-dimensional structure, these are three-dimensional representation of these molecules with the coils and how they interact with each other. You see they form pockets and they slide along the DNA, etc., etc.
Can you go back on that?
Yeah, sure.
Why? You have here MSH3?
Yes. Isn't that interesting?
Yes.
So
MLH1, PMS2, happy.
Yeah.
MSH2, MSH6, happy. But then MSH2 and MSH3?
Unhappy.
Unhappy.
Yes. So for those that know me, there's been a time, maybe about 5 years ago, that every meeting I used to go to, and people were talking about mismatch repair, I used to say, questions. That's me. You know, what about MSH3 and PMS1, you know, and people were looking at me and said, I don't know, the guy is mad. You know, and then I had to explain, you know, these are also other elements that can form dimers. And they were used to say, today, I don't know anything about it. Okay.
That's interesting.
Yeah. Let's kind of trying to think about it. And I had some interest because I was really curious to understand why there are 6 enzymes and we only chase 4. Okay.
Yes.
So this is a little bit more explanation. So these are the dimers. We retain this nomenclature, MAT-S and MAT-L. There is also a MAT-H because they do different things. One recognizes, one repairs. Okay. So MAT-S alpha is made up of MSH2 plus MSH6, but MSH2 has another partner, MSH3, so can form this other dimer that is called MAT-S beta. And you can see here, they actually look at different things. This is base substitution in small loops. This one is small loops and large loops, you know, because the DNA, when you make a mistake, can make a loop, you know, and those are recognized in these big loops, for instance, you know. Okay, so again, L is the system that repairs, you know, MLH1 and PMS2, traditional, but there is also another partner, PMS1.
Okay.
And look here, there is yet another L matter, MLH3.
Yes.
So there are options, and they do many things. For instance, in meiotic cells, the repair is done by MLH1 and PMS2, MLH1 and MLH3. You see, so they do something slightly different.
Okay.
And as usual, we pathologists are a little bit generalizing things.
Yeah.
We say there are only 4 enzymes, but there are not only 4 enzymes, but probably the 4 we look at are very important.
They're the most frequent.
Okay, but actually understanding this make you understand why sometimes you have loss of one and not of the other.
Exactly.
Okay, we will go into this. Okay, so if you stain a normal colonic mucosa, you will find that there is a gradient. And the gradient means that at the top there is very little staining. This is these enzymes resides in the nucleus, so these are nuclear staining. And the epithelial cells, and this is, it depends which bit of the GI tract stain and where is the proliferating compartment is mid-size, or down at the bottom, because in this case at the bottom, as you go towards the top, you differentiate, you stop replicating, you have no more reason to activate this enzyme,
Yes.
so you become silent. Some of these cells may be inflammatory cells that you see here, because you see there is a germinal center is reaching it, etc. Okay, so that's the normal mucosa, there is a gradient. And that's a carcinoma. And you may or may not see that there are cells that don't stay in this mass. This is the normal mucosa adjacent to it. Higher power, just to convince people. You see, there you are. You know, this carcinoma is absent. These are the internal controls, stromal cells and immune cells. And this is the partner, PMS2, is also absent.
Yes. So we are happy.
We are happy. And this is the other pair, MSH2 present, and MSH6. This particular one has a bit of background, nevertheless, probably interpret to MSH6. So why the pair disappear? So wild type, they create dimers, and these are stable.
Yeah.
A stable dimer is protected by the degradation from the ubiquitin system. If you have a mutant, a mutant partner, that's a mutant one, it can exchange with a normal one and create a and detach from the PMS2. When it's detached from PMS2, it's segregated. This is heat shock protein 70 is part of the degradation system, but the partner is also vulnerable because it doesn't have the protection of the other enzyme. And so they get degraded. So that's the basis of why usually we have a pair missing, but not necessarily, because you see now these are the possible dimers. So if PMS2 is degraded, MLH1 may be preserved because it may dimerize with PMS1.
So then why are we not testing also for the other ones? Do we have them?
Okay,
I mean,
if you've seen it, this is the question I always ask, and people say, I am the faintest idea. We don't know.
We are always happy when we have the pair and they're deficient, which is happy.
Yeah.
But when you have only one, then you start asking questions. Did it work? You're looking at the stromal cells, you're looking at everything.
Yes.
And then,
So my guess, and it's just a guess at the moment, is that probably defect in PMS1 in the areas of pathologies we look at, which is mainly solid tumors, may be completely an irrelevant proportion of the population. And you know what we are, we look at large numbers, you know, we're not interested in 100%, we are interested in 95%, we're doing very well. So maybe, I don't know, and the same thing for MSH3.
Yeah.
You know, so this is the concept. Cool. And rarely, but actually, so 2% or less than 2% of colorectal cancer that are mismatch repair deficient may have double hits. And this is a paper that describes one where there is concurrent loss, or two independently. And interestingly, so this is MLH1 continues to stay, maybe because he has a partner that protects it. PMS2 is gone. MSH6 is also negative, but MSH2 continues to be present, maybe because there is another partner that helps survive it.
Well, we've seen it's MSH3.
Anyway, these are rare cases, but worth to keep in mind if you have some odd result to say, oh, could this be
because
of
a different partner? Yes.
Okay, so interpretation usually easy, is there or not there, but sometimes can be difficult. So
definitely
difficult. So for instance, you have a situation like this where a lot of these tumor cells are not expressing, but some of these that are definitely tumor cells express. So it's heterogeneous. And in the past, we kind of used to ignore these things. It was it's just negative.
Yes.
Why does some? Well, because it's a tumor, it's a bit whatever. But now people started to put some order into it and started to think about that there can be heterogeneous expression, not entirely sure what it means, but they can describe it as being within a gland. So within a gland, there are positive and negative cells like the one I showed you, or clonal, there are bits of the tumor, whole glands that are negative or whole gland that are positive, or compartmental, the large tumor areas, like mosaic, like
exactly.
Yeah.
And especially when you have not two different tumor types, but the morphology is a little bit different, a well-differentiated and a poorly differentiated. Look carefully in both components.
So here, for instance, this is a compartmental, positive and negative. And this one should be intragranular, I guess. You know, this is half and half. Okay. So,
you know, but look, these pictures, I would argue a little bit because I'm looking at the stromal cells and I don't quite see.
Very good point.
Staining.
So, very good point. So here,
I will be a little bit.
Here one would say, oh, this is loss, but intragranular heterogeneity.
Yes.
But you're right. You know, the stroma, it's almost no staining. And I think you need to be, this is, for instance, MLH1, same thing. A few cell staining, lots of cells the same, but the stroma.
Your internal control.
Yeah. So we need to be aware of poor pre-analytics because these enzymes are very susceptible to bad treatments.
And especially, I think, on large specimens, on excisions.
So keep your eyes open and make sure that you're happy that the immunohistochemistry work well. And we haven't spoken about on-slide controls. I kind of deleted the slide accidentally, sorry. So the point of the on-slide control would be, why do we need on-slide control? In that biopsy, there would be some normal, possibly, but even if there is no normal glands, there will be stroma and immune cells, etc. They're the internal controls. So some people say we don't really need it. The classical thinkers say you need to put in it a control where you can demonstrate you do not stain a deficient for MSH1, a deficient for PSO. Okay, but this is a lot of controls that we need to put in.
Indeed.
So control for the negativity. And then my line of thinking is that, yes, there are internal controls, but you don't really know the tissue.
Exactly.
Yeah.
And I think in a setting of poor pre-analytics, I think an external control would be very helpful because like this, it sets you, okay, this is how a proficient should look like. This is how this should stain. And then you can compare a little bit with, even if you have that staining, even if you have a weaker staining in the tissue and you have the mosaic, but it's very weak. Yeah. And then you would think how you should interpret it, give you a balance over there.
So you can see that actually the on-slide control adds a little bit more into your assessment of difficult cases. And also you can compare. So the on-slide control is really useful to check for shift, drift. Sometimes very slowly your immunohistochemistry become very strong or very weak or very weak. And but you notice because the control, this control is stronger than before. Why? And so the drift is on the on-slide controls, which you are not going to be able to detect because every piece of tissue you test is a different piece of tissue and it's kind of more difficult. Okay, so we're doing very well on time, 20 minutes past. And we really wanted to talk about 3 more points. The silencing of MLH1 gene expression is really the silence of all these genes, but for some reason, MLH1 is the one that is much, much more often affected. So it's MLH1 silencing, then the story about EpCAM, and then the association in colorectal cancer with BRAF V600E and the significance of it. Okay, so methylation. Silencing. Silencing is most always due to silencing of the promoter region, and a prevalent way of silencing a promoter is to methylate it. Hypermethylate the promoter, it will not promote DNA copying transcription. And so if you have a case where you have loss of MLH1, if you really want to know whether this is a genetic issue, so there is a mutation, or even if it's not an inherited issue, if it's due to a mutation of the gene, or is an hypermethylation of the promoter, you ought to do a methylation-specific PCR. Sounds really difficult, but what it is you take the DNA, you chemically modify so that at points of methylation, you modify the base, And then you use two primers, one primer that recognizes uracil modified DNA and the other primer that is for the native. So you can compare the signals, and by subtraction, you say, yes, there is no methylation. So relatively simple to set up. Okay, so, and that would be helpful when you are asked whether a particular mismatch repair deficiency is linked, could be linked to a genetic inherited condition, or it could be sporadic, because methylation is sporadic. And in the setting of colorectal cancer, is most often associated with these tumors that have hypermethylation of the DNA,
definitely.
and then links up with another story that we'll tell you later is BRAF. Okay, so EpCAM, which as pathologists know it as BRAF4, and we use it widely for all kinds of reasons. So he is actually the next door neighbor upstream of MSH2. And what happens is that sometimes deletion involving portion or the terminal bit of EpCAM lead to either non-functional expression or non-functional MSH2 protein or methylation of the promoter. So it actually causes a defect of MSH2, but not because there was a gene mutation here, but it's because of EpCAM.
But in this case, then the MLH1, it would still
MLH1 will be expressed. This is for MSH2.
So then you will have only MSH2.
Yes, but
negative.
But remember also MSH6, because it's a pair.
Yes.
And if you have a non-functioning MSH2, means you can't come out of dimer. Both of them are vulnerable to degradation.
Every single one is going to be positive except MSH2.
Yes. So if you not except MSH2, MSH1, MSH6.
So also MSH6 is going to be.
Because it's the partner.
But then
it lacks protection.
Should we do in every single case like this also IHC for BRAF4?
That's the question. Because that will point towards.
Because if it is negative, then it's not mismatch repair deficient, because
it is still mismatch repair deficient, because in practice those cells cannot have a functioning MAT-S dimer.
Okay.
Because it doesn't work.
So if we have this problem with EpCAM, with BRAF4, what are the implications?
Okay, so the implication could be genetic, and this is a little bit of a little square here. They say clinical spectrum of EpCAM mutations. So this is the normal phenotype, EpCAM gene and MSH2 gene normal. Sometimes you can have some deletion or some mutations, and there is a upset of the promoter region of MSH2, so you don't have an expression of functional MSH2. Then these people are okay, you know, they're alive, fine. But then when a somatic piece of tissue loses the good alleles, then you cannot produce good one. So this is typically what happens in Lynch syndrome.
Okay.
For when you have MSH2 loss. Okay. Interestingly, it doesn't happen in endometrial carcinoma. So there are little kind of tissue-specific type of things. Okay. Then you have the situation when there is a mutation in or a deletion in the central regional cap that still creates a non-functioning MSH2, and the heterozygous can be unaffected carrier, but could have congenital tactic enteropathy.
Okay.
But these are people that survive adulthood. Interestingly, if you are homozygous, is really none of these things are very compatible with good development, and some of them may become, you know, may get to infancy. But really the outcome is not very good of these people. Rare, it's a rare condition. So this is kind of.
So should we do it or not?
I think we should.
So why are we not doing it?
Well, because we are lazy. No? Because
it's laziness, I think. I think it's like the workload, the amount of workload, and that little time that we have for research or for more interesting things to put into.
But now that you know, I hope the next time you have a defect of a
We'll
loss
put
of
that down.
message to,
So on the next
say,
mismatch
okay,
repair proficiency testing, we're going to have
a case with this. Okay.
Okay,
So here you see
good.
this is in this publication, you can see the normal, and this is the loss, and similar with EPCAM mirrors these things. And even here you see in this
Tiny,
not in situ, these are really micro regions, and they have affected by this problem. Okay. So the third bit that I wanted to talk about is the use of BRAF V600E as an antibody, and used in the triage of cancer of people that have diagnosed colorectal cancer, which is mismatch repair deficient, and should they be screened for familiar? Okay, so BRAF, this is a positive BRAF. So positive BRAF means there is presence of mutant protein. Otherwise, it cannot stay. It doesn't stay in normal protein. So a mutant BRAF is an indication that it's very, very rare that this patient will have a familiar syndrome.
Yeah.
There is a reason associated with it. And you remember we said a lot of cases with MLH1 loss, sporadic, have methylation.
Yep.
And in the hypermethylated phenotype, BRAF is often affected because because these patients have a lot of mutations, and BRAF mutations are very common. And then also makes sense to use the antibody in colorectal cancer because 99% of BRAF activating mutation in colorectal cancer is V600E. So essentially all of them, more or less. So it's good enough. We use the antibody. But if you want to try and do this trick on other tissue, it will not work because other tissues may have higher proportion of non-V600E, or because there isn't this link. This is just an association.
In colorectal.
Yeah, in colorectal. Doesn't really work in gastric, for instance. And this is the algorithm that we use. We do mismatch repair on colorectal on biopsies. If you have loss of one of the markers, you call it deficient. You reflex to BRAF. If it's positive, you kind of say this is likely to be sporadic. Yeah. If it's negative, so if there is the BRAF is non-mutant in V600E,
but should we
consider that referral to genetic? Yeah.
Should we not do also PCR to exclude rarer mutations? Before going to genetics?
99%. You need to think about the fact that these are screening tests. Yeah, you're not, genetics will do mutation studies, et cetera, and will do all the work cleanly, et cetera. The majority of your diagnosis of colorectal cancer mismatch repair deficiency will be sporadic. Yeah. If you refer all the sporadic, you overwhelm the system. Yeah.
The sporadic, the negative ones, in the moment that you have on IHC, BRAF negative.
Yes, indeed.
Before we should refer to genetics, we should try and do PCR.
Yes, indeed. But, and it depends in the settings where you work, because there are some genetic services that feel very, very jealous of the fact that you are impinging on their territory, and they say, no, if we want to do sequencing, we'll do it ourselves. Okay. Please don't do things we don't like to do. So it depends on how the local circumstances are. Okay, so that's the story of V600E. And this is an example. Small endoscopic biopsy, you can see here. I think there is loss here of MLH1, also PMS2. These two are preserved, BRAF mutated. So our reports say mismatch repair deficient, likely to be sporadic. Yeah. No, erratic to be, sporadic.
Yeah, sporadic.
Okay, so there has been some anxiety whenever we talk about these things that, well, you use the antibody, are not very precise. We saw a publication that say the antibody is very precise. So we've been using this antibody for donkeys, and let me tell you, there are some cases you cannot interpret. So you need to be sharp and say, uninterpretable, I'll do PCR. Yeah. But apart, if you are readily recognize these cases where it's danger, don't go there and take them out. Very few. I would kind of ballpark figure maybe 5% of my diagnosis would say indeterminate. Then the other 95%, they all coincide with anything. So this is one work, but our experience is similar, that if there is no mutation in NGS, the V600E is negative. and the mutation in NGS, the vicinity is positive. It works like a clock.
Yeah.
Yeah. And talking about these old things, remember I showed you this slide that was, in 1993, we understood that Lynch syndrome was linked to mismatch repair deficiency, but I think if you read the paper, they talk about microsatellite instability. Yeah. So what is microsatellite instability? The microsatellites are non-coding regions of the DNA, where there is short tandem repeats. Mutations in these regions don't really do anything, or allegedly nobody has reported that because there are mutations in this region, there is a danger for the patient. But there are surrogate markers to say, because these regions are unstable, it means that this guy cannot repair well, or these cells cannot repair well the satellites. So why? Because these are tandem repeats, or sometimes 3 or tetra repeats, and they are very, very prone to error in copying. So if you can't repair it, you accumulate a lot of mutations there. So if you then go and read these regions, you say, this is really unstable. There are dozens of different lengths of these repeats, where there should be only one length, because that's stable. Okay, so what does it look like? So traditionally, there were guidelines. For instance, these things here are primers for regions, particular region of DNA. These were the original ones, then they were modified. It doesn't matter. They look at 5 regions. Some people look at 7 regions. It doesn't matter. And then they say, if we find that there is instability in more than 2 of these loci, we call it high. If we find instability in 2 or less of these, we find low instability. And if they're all correct, we find it stable. Yeah. So this was the nomenclature. And in the old days, you used to do sequencing PCR and then gel electrophoresis, capillary electrophoresis, and you see this is the normal. You compare the normal with the tumor, and they're kind of matched. The weight of these satellites are more or less similar. But here, you see the noises here at this region here. It's really noisy. So that's unstable. Same here. Look how much is the spread compared to normal. So that's what you used to do. Obviously, now you can do it differently. You can do it by qPCR, either in a qPCR machine or in this now plug and play things. So you put the tissue section in a box and then press a button. And they use, this is a report coming from the EDILA. They use 7 regions of microsatellite regions, and they look at how many of these are unstable. So 1 means it's very unstable, and 0.00 means stable. So this one here has 2 unstable. So this could be low. Yeah. And this one here, look, all of them are unstable. This is high, if you want. Okay. But I would say now we should go away from this high and low. We now understand this microsatellite mismatch repair, Okay, so the third way of doing it, there are many other ways of doing it, but the third more generalized way of doing it is that you sequence by NGS or other ways. You sequence the 4 MMR genes and see if there are mutations. Yeah. And in fact, if you do this, you can have an extended panel. Do you remember all those molecules that were like big numbers? You can sequence all of them. So there is more depth in it, However, remember that even if you find mutations, it doesn't mean there is microsatellite. So all of these tests, when you compare to one another, they're not 100% agreement. There is always some agreement. Sometimes there is microsatellite instability, and the mismatch repair genes are all expressed. Sometimes there is mutation, and there is no microsatellite instability by DNA things. Okay, so this is a little table again. Lots of these papers that say, they agree, but not 100%. Yeah, definitely. That's the way. And this is the message. The message is that none of the tests we do, for a variety of reasons, will capture the entirety of the truth, and so keep it in mind. But again, Simona, we often say but none of our diagnoses,
Indeed.
they are 100%, really? I don't know.
We wish.
We wish. Okay, so so this was the terminology: stable, MSS, MSI low, MSI high, but now nobody really uses this. It's now either mismatch repair deficiency or mismatch repair proficiency.
Yeah.
Okay, cool. So that's where we are. Very good. So what about mismatch repair as a prognostic factor? And at this particular time, we stay in colorectal cancer. So if you see here, colorectal cancer stage is a prognosticator, low stage and high stage. This is the overall survival. Yeah. Cool. So if you divide the tumors per stage, stage 1, stage 2, and stage 3, and then separate deficient from proficient, you see that this is an old study. So in microsatellite unstable and microsatellite stable. Yeah. The microsatellite unstable at any stage, they do worse. Yeah. That's another paper that marries mismatch repair with BRAF. So this is wild type BRAF and mutant BRAF in the various combinations. This is a little bit the basis of that Cinecroc classification. You see the same stage, look how much difference there is, you know? I was waiting for you to ask me a question here. Why don't we use this thing? This is powerful data. You tell the oncologist, this guy is going to do really badly. Look, this one, bad news. Do something about it. This guy...
Testing. We are not testing BRAF if it is mismatch repair proficient, are we?
No.
Exactly.
But do you see?
So,
but do you see the power
yes,
this
yes.
segregation?
We are just when we receive in bulk. Okay, do all the testing from first, and especially if we are jumping on the IHC BRAF and we are doing PCR with NRAS, BRAF, KRAS. And then, yes, you're jumping and then you see it and you can make a comment, you know, pay attention, this is really bad.
But look at the difference between this guy and these people and these people.
Yes.
Yeah? Okay, just bear with me. Look at the difference between stage 1 and stage 4, you know, but we spend a lot of energy to make sure this is stage 1. We look at all the lymph nodes and all these type of things and look at the circumferential radial margin. We spend hours, you know, studying the section. And this is as powerful. It's an additional thing. So why are we not providing this? Why are the oncologists not asking for it? You see, these are the real questions. Okay. And again, more work. I mean, there is a lot of published work that say these things are telling you how these tumors behave. And therefore, you see here again, and therefore they are an instrument to say, this cancer needs adjuvant therapy now, or no need for adjuvant therapy.
It is very interesting that the proficient mismatch repair that have mutant BRAF, they are the worst.
Yeah.
All the time, they are the worst. And we are not doing BRAF.
Yeah.
We are not doing BRAF IHC from the start. Although the majority, let's be honest, the majority they do ask for PCR. They do ask for the KRAS and RAS, BRAF. So now it's included. But yeah.
Okay, so this is about prognosis. Well, what about mismatch repair as a companion diagnostic to actually try and select therapy? How do they respond to particular therapy? So this classically is studies that show that some of these cohort of patients benefit from the addition of anti-VEGF in their treatment. Yeah. So you can see here that the deficient and the proficient tumors, you know, have you bring you don't have a difference between the two, but the deficient tumors, you improve the outcome using anti-VEGF in addition to all the therapy. Yes. This is probably FOLFIRI, I don't know. Okay, so this one is, and then of course, what we spoke at the very beginning is access to immunocheckpoint inhibitor. And one cannot underestimate the beneficial effect of immunocheckpoint inhibitors. So, you know, this paper is about any solid tumor. And then just for you and me to understand, mismatch repair occurs in a lot of solid tumors. But of course, the three big ones is gastric, colon, and endometrial. in terms of percentage, but a few percentage each is everywhere. But we don't look for these things, you know, we don't look for mismatch repair in renal cell carcinoma,
Or
do we?
breast.
Or breast for the matter, you know, but
Yeah.
1%. But nevertheless, we chase 0.5 or 0.2% ROS1 mutation in lung cancer.
But we've seen the dramatic responses.
So later on in the presentation, there is some slides that show you how the response is very interesting. Okay, so let's talk about these other cancers. So it's not entirely certain whether mismatch repair deficiency in endometrial carcinoma is beneficial, better prognosis, or not. Actually, the other way around. Jury is still out. And but what is interesting to see is that since 2018, in the work of the Cancer Genome Atlas, the WHO classification say you need to use mismatch repair to classify these tumors. And this is the scheme, you know, you do poly, and if it's mutated, ultra mutated, that's fine. You call these are the ultra mutated tumors. If it's microsatellite insufficient here, but we know is instability, is hypermutated, and then using P53, you separate the high copy number from the low copy number. So this is the scheme that we use to provide a molecular classification. And this is a study that looks at the effect of pembrolizumab. This keynote is pembrolizumab, I think plus chemotherapy, if I remember correctly, plus chemo in non-treatable or non-responding to cancer standard of care advanced endometrial cancer, either deficient or proficient. And you know, this is the waterfall plot. So there's a significant response.
Because as far as I know, pembrolizumab is the only one approved for gynae.
Gynae, yeah. And then gastric cancer, you know, the molecular classification of gastric cancer also takes into consideration microsatellite instability or mismatch repair, and it's again a cascade. You know, things look like that. You do EBAR, then mismatch repair, icadinin or beta-catenin, or both of them, and then P53. And then as a consequence of that, these are now the mandatory biomarkers for colorectal cancer, which is HER2. And HER2 we ought to sometimes do something about gastric HER2, because in our experience, gastric HER2 immunohistochemistry is not sufficient. No. It's almost never sufficient. No. You really need to also do the dish. And then PD-L1 with 22C3 and Claudin 18.1 just now. But the markers, you know, they're evolving, you know, there are the folate receptor alpha, you know, these kind of things are all coming up, and then we need to gear up to respond. Okay, so this is, for instance, an endoscopic biopsy of gastric cancer. You can see this is the tumor here, and that's the normal mucosa, and this MLH1 is gone. This is PMS2.
It doesn't look exactly normal mucosa over there.
Just a moment. I had
a little bit of mixture.
Yes, so I had a high power of this, but I lost it, and there is a bit of background, but the nuclei of the tumor cells are lost. I'm sorry, I cannot show you, and these are preserved here. It's usually are quite easy. It is quite easy to interpret. Okay, so
I think this we showed.
Showed this already. Okay, so
with the response.
These are response. So completely, we haven't spoken about that. You saw that table, breast 1% mismatch repair deficient, but this patient had breast cancer, mismatch repair deficient, metastatic to the esophagus, I think, or stomach. That's it. Essentially untreatable. These patients will die.
That looks like stomach, though.
Yeah, it looks like stomach. After treatment with immunotherapy, there is no more an ulcer, you see. So it's really dramatic responses. And this is a prospective study that was published in 2022, I think, where there were a number of patients, colorectal cancer patients. Look, this is an endoscopy view.
Wow.
And this is the radiological view before, 3 months during chemotherapy, and then at the final, and this is the PET scan. So these are complete responses, so much so that they're now thinking of not excising anymore. And this is another patient, again, advanced, and then complete response here.
But right now, is nothing approved for colorectal? PD-1 or PD-L1?
So now I think no, because the neoadjuvant chemotherapy is chemoradiation.
Yes.
But I think there are trials where they
had trial, and I think with pembrolizumab, but it's nothing approved.
No.
Although we do receive quite a lot, rectal and colorectal.
From Europe.
Yes.
Probably.
Yes. Yes.
In UK, we are not really all that progressive. And this is just to show you that the original biopsy, and this is post, so these patients were rebiopsy, were not excised. This is a biopsy after immunocheckpoint inhibitor therapy plus chemotherapy. And all of this is all necrotic tumor. That is residual. There is no residual viable tumor. Okay, so it's Q2. This is kind of summary. Mismatch repair, this is our Dr. Lynch, can be inherited or sporadic, mismatch repair deficiency. In the most simple way for pathologists, we can look at it just by doing immunohistochemistry for 4 enzymes, detects the majority of cases. The interpretation sometimes can be difficult because perhaps there is mosaicism, or perhaps there is poor pre-analytics, and you need to look out for it. In some cases, the mismatch repair deficiency is due to silencing methylation of the promoter, and may be worth exploring this. There are orthogonal tests to enzyme to immunohistochemistry that could be used or should be used in difficult cases where when you are in doubt, you reflex to another test and see if they are concordant. Indeed. And then you can be more robust in the diagnosis.
Yes.
But remember, nothing is always 100% concordant. That's the reality of life. We said EPCAM could be used, and I hope that Simona will use it now in the future if you have loss of SH2 or 6, well, they go together. And we saw how V600E can be useful to identify sporadic cases. Mismatch repair deficiency can be prognostic and predictive, and identify responders to immuno-oncology, and they can be dramatic, the responses. We also, had a little journey into other solid cancer. We spoke about endometrial carcinoma, can need to be classified molecularly. We spoke about also gastric cancer needs to be classified molecularly. Basically, the message at the end of this is that your diagnostic service needs to evolve with the necessity of things. And I think this is the end of my slides, and we can stop sharing, and we can have a look at one comment. This is too small for me. Okay. I'll open on screen. It will be here. Yes. One comment says, interesting study suggesting that functional mismatch repair component are required for some, but not all of the 40 odd known microsatellite expansion that cause disease, e.g. Huntington. Yes. When you start to listen to some of the presentations and the seminars in genetics, you realize the blooming thing is so complex, and I will never understand it really.
But I think from my point of view, what is very useful, like you said, take-home messages, and is to be aware that the pairs that we know, they are not defined. Like you can have other pairs, you can have other partners that can form that pair in the end. So if you have one deficient and the other one proficient, don't jump to conclusions, think, oh, it's just a mistake, or why and how.
Yeah. So probably when you have this discrepancy, probably the message needs a little bit more investigation.
Yes.
Just to make sure it's not a mistake. It could be just an error of your immunohistochemistry, etc., etc.
Yeah. It's not just a mistake, I think.
Yeah.
Yeah.
Okay, so we still have a few minutes. Please make some comments or unmute yourself and make some comments live. In the meantime, I wanted to tell you that we are opening a circulation for. It's already open for colorectal cancer. It's usual circulation of proficiency testing, and then we'll have a little chat at the end of it in 2 weeks' time or so. 9th of July. It will be open until 9th of July.
Okay. I think I would like to ask a question maybe of the audience if I think this information and the theory is very useful because we can have an understanding about exactly what we are doing and how we are interpreting, but also if we should spare 10 minutes at the end of some cases, very short, I don't know, more tricky cases or something.
To discuss?
Yes, like also to give some examples, what we've said as well, with different components, with different, or if it's better just to put them in the proficiency testing.
So I don't know
maybe,
what you guys selected for the proficiency testing.
To be honest,
but I think certainly we could, in 2 weeks' time, also bring you some examples. I think I want to show you the comparison between enzyme, immunohistochemistry, and microsatellite instability. I think that's also useful. Okay. To see to begin with, but also if we have some interesting cases.
Right, that's what I was thinking now, because we started doing as well to reflect some of the cases more. I don't know if NGS necessarily, but definitely to ETLI and things like this. Yes.
PCR, to cook this.
So yeah. When you should cross that line and say, okay, step back, is from my point of view again, and I do have this feeling, I just want to solve the case, move on, next case. But some cases, they are not just easy and tick boxes, let's say like this. And when you need to pause a little bit and say, okay, I think, like Corrado said, this needs a little bit further investigation and not just authorize a case quickly.
There is Richard is posting something, perhaps like other EQA, could have scoring and a few non-scoring cases. We can do that, obviously. But the problem with the other EQA is that if you perform badly, they send you a letter that say you are really not very good, and you really shouldn't be doing these things for real. And I think our is not really an EQA. No. Our is a circulation to make sure that you feel comfortable, that you are concordant with the opinion of the others. If you're not concordant with the opinion of the others, it doesn't really mean you are wrong. And this is what my big objection to EQA. Sometimes the EQA have difficult cases, and I know that in the EQA circulation, there is one guy that knows the diagnosis, but because it's the only diagnosis, he's told he's wrong, but he's the expert. That's the right diagnosis. And then we go with consensus. That's like, I don't know. So yes, we could put non-scoring cases if you want, but I think we could all score it. I mean, it doesn't mean anything.
I think the most important is to understand how to approach cases and certain cases. What's the next step when something gets more difficult or more tricky?
Yeah, we can call it routine. I agree.
So maybe call routine. Yeah. Okay. What is the concordance of isolated MSH6 loss, PMS loss, and MSH status?
Okay, so these cases are microsatellite unstable. These cases where you can demonstrate mutation in concordant mutation that I know of, they are microsatellite unstable as well.
And the next question is, would you mind to compare the difference between MMR in colorectal and endometrial?
Yes, but sure. So a lot of the rules we have to interpret mismatch repair in colorectal cancer are really empirical rules that apply to the fact that some circumstances are very rare in colorectal cancer, so therefore we'll ignore. Instead, in endometrial cancer are more prominent, and therefore we pay more attention, etc., etc. So, but maybe we should do a little session on endometrial carcinoma as well.
We could. We could.
Yeah.
And also, it's the same thing like Corrado was saying. This is mainly, and I think, I don't know if I'm saying right, if it started with colorectal cancer, or people are more aware of MMR mismatch repair in colorectal.
It started with colorectal.
Now, exactly. Now we are starting a little bit more wide with endometriosis already, but especially in gastric now. and we are starting even more and more. And each organ has a little bit different.
You know what I was thinking?
And percentages.
I was thinking at that case that was microsatellite unstable breast cancer metastatic. Yeah. And I was thinking last night, I was reporting a case, urgent case for a patient with breast cancer metastatic to the liver. And this was triple negative. And the oncologist said, oh, let's do quickly PD-L1 because I really would like to give the option of immunocheckpoint
Why are you not doing
inhibitors.
MMR?
And that was negative, unfortunately. This was a liver biopsy. And my comment was, it's a liver biopsy. Maybe we should test the primary because, you know, in liver biopsy, it's less often positive. And then I was saying, and then she wrote back to me by return to say, well, the primary is ER positive. So this was a complicated case that became triple negative under challenge of therapy. It's not really a triple negative breast cancer. So I was telling her, yes, maybe we should study ESR1 mutation and AKT and P10, et cetera, and PI3 kinase. But now I was thinking, why did we not do, or should we do microsatellite mismatch repair in this case? Because if she is deficient, and she has access to,
yes.
She's already in second line. So you see, you know, maybe.
Is it just Pembro if it is mismatch repair deficient, or is also Atezo?
I think it's Pembro in second line.
Only Pembro. Okay.
But she's already in second line.
Oh, okay.
So you see, I think sometime, and I just thought about it now today while we were talking, but last night I didn't think about it. And this is an example why pathologists,
And another question, just to add on, would you be all right giving the patient immunotherapy with isolated losses, or would you like to confirm to show MSI high status?
You know, I don't treat anybody.
Indeed,
I don't know. I mean, the concordance are very high. The concordance is very high. And also, we say, this is another thing that I am really struggling with in my brain. We say that the group of patients with something have benefit or no benefit from a certain treatment.
Yeah, but you don't know
the
outliners.
Each patient, you know.
Exactly, there always can be outliners.
So I think the first hurdle is this patient has access to the treatment. And access to the treatment is because somebody writes a report and says mismatch repair deficient. Okay. Then the second bit is it going to benefit? I don't know. You know, that I don't know, because even if in the non-responder arm, there will be responders, only God knows where they are. And, you know, this patient I was telling you about, this breast cancer patient, was HER2 low. So I wrote back to her and say, but I just checked, it's HER2 low. It's an HER2. And she said, but she's in England. She's got no access to HER2 low.
Go to Ireland.
She needs to move to Scotland.
Exactly why you said this with the responders and non-responders and the outliners. The only thing that I was thinking right now is the same thing with the HER2, with the D-dish. When it is positive, there are no amplification cluster. It's just positive just above the threshold of ratio of 2. And we're saying, you know, it might respond, but we don't know.
But usually
in the blood responding,
patients the responses are very low as a group.
But we are calling it positive because the ratio is above 2. Anyway, okay.
Very good.
Thank you very much.
Thank you all for your patience and for your comments. And we'll see you in a couple of weeks' time.
Yes. Thank you.
Bye-bye.